All right, let's go ahead and get things started. Good afternoon or good morning, depending on where you're joining us from around the country today. Welcome to today's webinar, Supporting Community Health Workers in a Changing Environment. Next slide. So just wanted to give you a quick overview of our agenda. So today's webinar is brought to you by a partnership with the Association of Clinicians for the Underserved and the Pfizer Multicultural Health Equity Collective. And the big focus or part of this partnership really focused on conducting a number of focus groups. So today's webinar is going to really dive into those key themes and panel discussion. But we're going to give a little bit of a national landscape or touch on the national landscape of CHWs the CHW workforce within health centers across the country, and then have a panel discussion that touches on those key themes that came out of the focus groups. And then instead of just a traditional Q&A at the end of the webinar, we're going to have a discussion. We're going to ask you several questions about your perspectives of the future for the workforce, of the future role of community health workers in this country. So with that, let's go ahead and go to the next slide. So a little bit of a background on the Association of Clinicians for the Underserved. So we were founded in 1996 to be the advocacy voice of the National Health Service Corps, and have since expanded in the last decade or so to support the recruitment and retention of the healthcare workforce at community health centers across the country. Go ahead and go on to the next slide for me, please. So with that, I'll go ahead and turn it over to our partners at Pfizer and turn it over to Renika Alexander. Renika?
Thank you so much, Luke. It is just an honor to be here today, and I'm here representing a crucial part of Pfizer. It's the Pfizer Multicultural Health Equity Collective. A little bit about the collective. It's really been in place over a decade, and despite having so many partnerships across our organization, we knew that there was a need to really address persistent health inequities and really more holistically work with our communities, and thus our Multicultural Health Equity Collective was born. So you'll see that on the slide here. On the left, I'm sorry, on the right, on the picture, you'll see many of our internal and external partners, our leadership here. We're a cooperative of 50 plus partners. We started out with just under 40, and now we're over 50 partners across the United States who are working to improve the health of marginalized and underserved communities. And so we work together to create space for leaders. We not only seek to address health disparities, but we also want to disrupt drivers of inequity. And our foci are these four pillars that you see at the bottom. So you'll see health care delivery, and health facility inequities. We're looking at research and data. It's critical for us to have data infrastructure that is supportive of our most marginalized communities. We concentrate on workforce pathways and also policy, which drives the conditions our patients are really living and achieving their health outcomes and receiving their care under. We'll go to the next slide. And you'll see I have these four pillars outlined once again here, but workforce pathways is really critical for us. This has been a topic of many, many discussions. It is really highlighted in our action guide. I'm not sure if you have a QR code to that, but we can make sure you get a copy of that. But to two of our health equity summits, first in 2022 and 2024, we really wanted to touch base with leaders, folks from the community health worker community, as well as policymakers, clinicians, to really understand what those drivers were, what the needs were around workforce development, and how we could be of a support. And the pictures you see on the side are from our 2024 summit. Again, those leading to our action guide. And thank you so much for that link. And then I'll share a little bit about some of what we've been able to accomplish. So, of course, we want to hear from those partners and healthcare providers that are really responsible and critical folks who are engaging with community health workers and staying right on the front line what's faced by our healthcare workforce. And so we have federally qualified health center steering committees, one of which we just had recently, that really helped us gain some insights on how critical the community health worker workforce is to us being able to really increase trust in science, be able to connect with patients that have not traditionally been focused on. We saw really an elevation of that role during the pandemic, and we're continuing to focus on understanding how we can support them. We've worked with the National Minority Quality Forum actually to talk about the role of the community health worker in delivering critical education to patients. We want to make sure that they are having the educational materials, the opportunities that they need so they can optimally serve their patient. And we work closely with the National Minority Quality Forum in that capacity. Again, focusing on actually hearing the voices and co-creating with our community health worker workforce is really critical for Pfizer. And we've done work with a number of different organizations. We were a part of the Unity Conference and presented an abstract there talking about the critical work that we've been able to do in Houston with a number of organizations located there. So we do have our action guide that was now linked in the chat. Happy to share more about that. Please feel free to reach out to me or Luke and to hear more about the work we're doing with the Multicultural Health Equity Collective. So thank you so much.
Thank you. Now, I'm Sarah Gudma. I work at ECU as a program manager, and I just wanted to start off the conversation by talking a little bit about what the community health workforce at community health centers looks like. Uh, so, the national workforce of community health workers is growing quickly, over 65,000 in 2024, with an expected 11% growth according to the U.S. Bureau of Labor. And at community health centers, it's also a small but rapidly growing workforce. So according to UDS data, community health workers make up about 1% of the total community health center workforce. However, the total community health workforce nationwide has nearly doubled in the last 5 years. And just to give you a sense of what that looks like, again, this is according to UDS data, looking at community health workers by state. The range in the number of community health workers varies widely across the country. As you can see, states in red, it's about 0 to 30, while states in blue are 200 plus. So as you can see, as states get going with community health workers, they are quick to grow their programs. And we'll hear a little bit more about why that is and the impact that community health workers have. Now, in terms of what it actually looks like to be a community health worker, you'll hear quite a bit from us sharing our focus groups and our panelists, but I also wanted to pull out some numbers from the National Association of Community Health Workers survey that was produced in 2021. So they identified some key barriers to success for community health workers, looking at their limited role funding, training and certification costs, as well as education requirements. And additionally, the related to the salary cap on this role, because again, we'll talk about in a little bit more detail in terms of how these roles are funded and whatnot, but wanting to make sure that community health workers have the chance to grow and advance within their role and have a salary increase that reflects the growth of their responsibilities. Finally, only about 46% of community health workers agreed at the time that their compensation is equitable and offers a living wage. And they also feel somewhat limited in terms of leadership opportunities within their profession, as well as not feeling fully recognized as part of the care team. So there are a lot of unique challenges that the community health workers face. We'll hear a little bit more from each of our panelists about this as well. So in our focus group, we had 9 focus groups over the course of this fall, 6 with community health workers directly, 1 with community health center leaders and administrators, 1 with primary care associations, and 1 with state or regional level organizations working in this space. We had representations from 12 states across the country, east to west coast, and also working in very different environments. Some community health workers were in more rural environments, some were in more urban environments as well. So today we're going to hear a bit more about how the support for community health workers requires large-scale collaboration. We'll share some of our focus group findings and hear from some of our focus group participants who engage in community health worker work at different levels. In our focus groups, most community health workers transitioned into this role from other clinical or social service role. They were looking for mission-driven work, many after experiencing burnout in a prior position, but many were drawn to the role because they saw gaps in their community, and their lived experience and community relationships and trust really helped to shape this workforce. I'm going to hand it over now to our panelists to introduce themselves. Anna?
Hey, good morning, guys. My name is Anna Estrella. I am a community health worker, boots on the ground community health worker here in Mountain Home, Idaho, and I am representing Desert Sage Health Centers.
Fantastic. Ton?
Hi, everyone. My name is Tom Moraz. I am the Community Health Worker Project Director at the University of Kansas Medical Center and manage CHWs, do training for CHWs, but I also am a CHW after 5 p.m. most days. So nice to be here. Thank you so much.
Thank you. Triva?
Yes, hi, my name is Treva Smith. I am Workforce Development Specialist at Community Care Network of Kansas. It is the Kansas Primary Care Association, but just like these other two, I am a CHW at heart. I've done CHW work, and I also work on the board of directors for the National Association for Community Health Workers. And glad to be here. One of my favorite topics.
Fantastic. So excited to hear from all of you today. So we wanted to start off by talking a little bit about funding. So in our focus group participants indicated that a lot of their community health worker roles were heavily funded by short-term grants. There were states, or there were participants from states where Medicaid reimbursement exists, but it's often underutilized due to low reimbursement rates, limits on what can be reimbursed, such as requiring face-to-face interaction, which limits phone calls, off-site visits, and those sort of things, as well as the administrative burden required to do all the work required for submitting a Medicaid reimbursement. Now, Ton and Treva, could you talk a little bit more about what has supported Medicaid reimbursement implementation in Kansas?
Triva, do you want to start?
Sure. I'll go ahead and give a start. So here in Kansas, and me and Tom both, we've been working together on this topic for quite some time. But um, the biggest things that helped us is cross-sector partnerships. We have partnerships all across the state, from KDHE to community-based organizations and other CHW leadership, clear state infrastructure for CHWs. We had our core competency course was already up and going. Our voluntary certification process was up and going, which was huge. We had data and advocacy had already, begun and was started. And so all of these things were huge for that. And I think Todd could probably talk a little bit more about some pilot programs and some technical assistance that have been offered through programs he worked with.
Yeah, and as Triva was saying, the collaboration across the board with Kansas, the different organizations, that was integral for this process to go forward. If we didn't have that collaboration, Medicaid reimbursement wouldn't have happened in Kansas. The other thing that was also important was the openness of Medicaid to begin to have these conversations, because I've been having conversations with other states. They have everything that they need, but Medicaid is not open to have those conversations, at least yet. And so they allowed us to meet with them to talk about the need of the reimbursement for CHWs. And then, as Triva was saying, in terms of like technical assistance for organizations, I have to give kudos to the Kansas Department of Health and Environment. They have a great team there, including Jackie Catron, who is one of the directors. And they went above and beyond, going to the different clinics and engaging us as well to different FQHCs, health centers, and talk to them about the role of the CSW and how they can get reimbursed by Medicaid. Every time that I have a situation with clinics or organizations that want to get Medicaid reimbursement, I can count on them, on this team, to help us to go through the process. They develop a toolkit that allows organizations to understand how the reimbursement works. So it's a group effort. It has been a group effort.
Sure.
Thank you both so much for sharing. Another thing that came out in our focus groups was the alternative funding sources that health centers use. So for many that they rely on payer incentives, ACO REACH funding, pharma device funding, sponsorships, as well as flexibility of FQHC operational dollars. But these sources can sometimes be inconsistent. Uh, but it's important to note that the work that community health workers do, even that which is non-billable behind the scenes, can help drive completed visits, screenings, and improved outcomes. They are helping to get patients to care, connecting them to the providers who are able to bill for those services and making sure that the quality outcomes and whatnot are being met. So, Anna, could you talk a little bit about how your role in a state where Medicaid reimbursement for community health workers is not currently available is supported? And do
Yeah.
you feel the wages of community health workers are fair and representative of your value?
Yes, definitely. So I just really want to thank Treva and Ton on touching on that. It's a group effort, and I believe that Idaho is gaining traction very quickly. And so it really takes a whole team, a whole village to get this going and get this up and running. So kudos to the people who are doing this and advocating for CHWs, and especially in a rural state like Idaho. As far as compensation, I always say that being a CHW is not for the weak and not for the get rich. But we do have support, and um, here at Desert Sage, the program was so new. So they started pretty fair as far as pay compensation. But now that we are in year two, we're getting a better perspective of, what a CHW role is and how we're going to go ahead and incentivize that whole program. And so I just feel like compensation at the moment, it's hard. It's very, very hard. Sometimes I find myself getting the resources I'm helping other people get because of compensation, but I feel like we're gaining traction and getting on the right track of getting CHWs better wages.
Thank you for sharing. Next, I want to talk a little bit about professional development. So community health worker training covers a pretty broad stretch, and a lot of this, again, varies based on where you're based, what your community that you're serving looks like, and whatnot. But they touch on a lot of key skills, such as the one we mentioned here, navigation, outreach, health education, cultural competence, and others. And additionally, a lot of community health workers are able to go above and beyond with support from their organizations. Members from our focus group provided examples such as building additional skills and certifications as medical translators, building additional skills in the behavioral health space. Again, really working to grow themselves and grow and respond to the needs that their community has. However, while there's a lot of great flexibility and responsiveness in the community health worker role, there are a lot of limitations and variations across states. For example, in certain states, community health workers are not able to directly engage with things that are directly connected to medical practices, like helping patients monitoring their blood pressure, blood sugar, etc. So training for that can vary. And now, Tom, could you talk a little bit about what some of the training opportunities look like in Kansas with the COPE project and how it supports the training of community health workers?
Sure. So I have to say before I start that I feel like we have a really robust core competency training here in Kansas. It's 160 hours, 100 lecture, and 60 hours of service learning. But one of the things that we've noticed as CEWs were going through the training is that they will come out of the training and the pragmatic piece was kind of missing, where CEWs will not know exactly how to assess individual needs of a client or how to physically document encounters, etc. So there are several efforts in Kansas. This is not just the University of Kansas. There are different groups that are teaching the core competency curriculum. And so through COPE, that stands for Communities Organizing to Promote Equity. That is a collaboration that we have with the Kansas Department of Health and Environment. We got the opportunity to get over 60 CHWs hired and trained. And so we created like alternate trainings that the CHWs needed beyond the core competency training. So some of those trainings were like healthy homes, where CHWs will do a home visit and will assess the house in a non-judgmental way. So they will go there if there is mouse droppings, if there is humidity, if they have smoke alarms, etc., and have those conversations and see how they can help the clients. That's just one example. But COPE allowed us to develop extra curriculum for CHWs. And now currently, actually, Triva is going to be co-teaching a training with me, a core competency training that starts in February, where not only we train the CHWs on the core competencies, but we are going to have professionals training the CHWs on mental health, substance use, public health. And from there, ensuring that there are other trainings. The service learning, we are going to do like workshops and discussions with the CHWs just to make sure that they are also well connected. And we are trying to implement a mentor-mentee program for community health workers. So it has been a great opportunity, and we continue to do that. Beyond that, we are developing trainings like the Quick Start training and CHW labs, where CHWs that left the training, they completed the training, and they feel like they don't have the skill set that they need in a specific area, they can come to the CHW lab and practice with people from the community to enhance those opportunities to get better at their job.
It's really exciting to hear all of the great work you're doing to help your community health workers thrive in their roles. And Trevor, you're clearly deeply involved in this work. Could you talk a little bit more about how the Kansas PCA supports the continuing education of community health workers as well?
Yeah, from
Triva,
the
probably.
from the PCA level, there are several things that we currently do, but there are more things that we can't be doing, and other PCAs may be better structure to do. But I want to talk about a few of those things. And one of the things, of course, is providing training and professional development. One of the things that we've done here in Kansas is we have provided scholarships and things like that for CHWs to go to an annual symposium, which offers several different opportunities for continuing learning. There's also support for certification. We have certification here in the state of Kansas, and so we supported CHWs in our health centers to know how to go about those certifications, and then also how to track for recertification. Creating learning communities is a wonderful way, and Tom kind of touched on that and some of the things that he wants to do, is creating that learning community so that CHWs can get together and kind of learn from each other. Partnering with other training processes. We partner with some community colleges throughout the state to help provide some of those trainings, and offering some technical assistance. That's one of the big things that we like to do here at the PCA. Any workflow, that folks need help with as far as documentation, billing, how to go about billing for that, and then sharing resources and other updates, policy updates as it relates to advocacy and that kind of thing for CHWs. And those are the major ways that I feel that a PCA could help.
Fantastic. And Anna, can you talk a little bit about the trainings and support that have helped you in your professional development as a community health worker?
Yes, absolutely. So, like I said earlier, the CHW program here at Desert Sage is fairly new. And so I had free range to go ahead and start and create the program how I see fit. So just getting that support from my managers. And then ISU, Idaho State University, they launched off an amazing community health worker apprenticeship here in Idaho, and it opened up a platform for all CHWs to kind of communicate and grow with each other. And also, we've partnered with CHWA as well, and they opened it up for CHWs to talk to CHWs, because sometimes even with the people you work with, they don't understand what exactly is going on in your CHW world because we wear so many hats. But ISU, Idaho State University, shout out to them because they tailored this apprenticeship where we have core and advanced competencies and also a practicum where we are gaining learned experiences and gaining foundational skills to go ahead and tailor the CHW program as we see fit for our community. So that has been a tremendous, tremendous help, and also helping me create the CHW program here at Desert Sage. Like, what are we looking for, and what do we want it to look like, and what are our goals, and really giving me the foundational skills to go and make partnerships, go and find those buy-ins. Who am I looking for? What am I looking for? And things of that sort. So it's been amazing with ISU, and it's just ah. But yeah, as far as advocacy, or I'm sorry, the support that we got from NATRA is just getting us to that next level from CHW work on the ground. Like, what next? And so getting that information from NATRA, which is CHWs from all over the country, going to that Unity conference, it really opened up my eyes. Like, we really need to get the word out, get these CHWs certified, get them recognized that they are the secret sauce to medical care. Mic drop.
It's great to hear your excitement about the future of the role. Um, Moving on to our next topic, we wanted to talk a little bit about the keys to success for community health workers. So, again, something that was again continuously emphasized in our focus group was the community health workers' lived experience and community trust as core strengths, that engagement with patients and the ability to respond to those needs is central to the community health worker role. Focus groups also highlighted a couple things such as role clarity and protecting their scope of work, and key supports like responsive supervisors and champions who help connect and integrate them with the care team, as well as inclusion within their team huddles, and building and addressing larger social determinant of health partnerships outside of that work. Anna, could you talk a little bit about your keys to success at your role that had not been previously defined at Desert State?
Yes. So let me just tell you that when I first started this program, the biggest barrier that I had was, okay, this is a provider dumping ground. They were dumping all their dumpster fire cases. And so they didn't really understand what the program was meant to be and what exactly I was able to do. So what really helped me was getting my supervisors to understand what that role looks like, what my role looks like, and then getting that provider buy-in. It took me about 7, 8 months because I started highlighting success stories. They saw these patients coming back in the communication between providers and myself. Now they look at me like they're hands and feet for the patient. So when they can't get to the patient, let's send Anna because she can do this. And I have an open door policy where you can come and ask me. I've made many connections, and I've been very, very fortunate to be in a community where they were so accepting of me. But one of the way I got there was making myself available for community outreaches, community events, community volunteer work. I do Meals on Wheels for the senior center, making my face familiar to the community, who then, because I represent their provider, they're like, okay, we can trust her. So that has been the key to success for our program here, is just making myself available and being transparent and being clear with the yes and the no's.
Totally. Ton, how have you seen community health workers effectively respond to the needs of their communities?
One of the things that is very important and is embedded on the name of the CHWs, community health workers are meant to be working in communities. And I'm not trying to criticize any CHW program, but those CHW programs that are having the CHWs working just on the phone, they don't have that extra connection with the community, with the partners in the community, with the patients. So that's very important. With that said, one of the things that I have seen that has been very, very successful is how community health workers have been working, at least in Kansas. I'm going to say with the programs that we have here, uh, there were coalitions developed in different counties, and those coalitions were comprised by people from the community that suffer, that eat, that pray, that play, that does exactly the same things that we do, right? So CSWs were part of them. Those coalitions were deciding what were the challenges in the community. And so when you see the CSWs going above and beyond, understanding, what the issue is and being able to advocate for it, it it's just glorious because the CSWs are not just meant to be working one-on-one with clients, was also working with the community at large, you know? And I can put a couple of examples, and Sarah, you tell me if this is appropriate. The example that I mentioned about the BPU. So think of this: Wyandotte County, for several years, Wyandotte County is one of the poorest in with the worst health outcomes in Kansas. It's almost like consistently on the bottom. So the BPU for utilities didn't have a program that will help people who wasn't able to catch up with their bills. So they will cut their services in a heartbeat. And so then CSWs were working with those clients, and you will see clients. We had a patient that was in labor in her house because she couldn't afford to go to the hospital, and the power and the heat was cut off, the electricity. And so examples of that cannot happen, not in Kansas, not anywhere. And so the CSWs began to compile a list of situations like that. They suggested to create like an audience with BPU, and they told them about those cases. And they were like, if you only were to be able to create a planning for people to afford those payments so they can pay a lower rate for X amount of time and they can go back and catch up, that will save time, lives, resources. And so after taking serious consideration on that, BPU decided to implement a program for people to catch up with their bills. And so that was pure advocacy work of CSWs. I have seen many other ones with mental health for youth. I have seen any other ones for, there was another one that was important as well. But even at a legislator level, I brought my CSWs. We screened a documentary about CSWs, and they told their stories to the legislators. And I was happy to pass around clinics to the different legislators that were there when they saw the work of the CSWs. So I'm just going to stop it there, but I hope that kind of helps.
No, Tom, those are super powerful examples of the impact the community health workers can have when they're able to advocate for themselves and their communities. Um, Triva, could you talk a little bit about community health workers advocating for themselves on the national stage?
Yeah, as Tom, talked about, those are the ground level type things, but CSWs are now moving into the national spaces as well as it relates to advocacy. We have folks who are working, CHWs who work with CDC and with HRSA and APHA, but NASHWA, the National Association of Community Health Workers, has for the last 3 years held what they call Heal Days. And I have a little bit of data there from last year's Heal Day. There was a total of 63 CHWs that joined the Heal Day with 22 allies, so a total of 85 folks participated. We had 31 states represented. 59 House districts were reached, 58 Senate offices were reached, with a total of 121 visits. And so, as you can see, there's a lot more work being done, even on that national stage. But some of the other, one of the other takeaways that we had was we had a broad Organizational support. We had over 274 sign-ons. We had solid participation from geographic reach. We had we had bipartisan, so we reached 77 Democratic representatives and 42 Republicans. And so, as you can see, like I said, this is a bigger thing than just one area. It's more than rural, it's more than urban. It is a nationwide situation, and there's a lot of work to do. And CHWs are moving the needle in health across the state. Also, just to mention our FQs, we had about 5% FQs represented on that Hill Day as well. So those are the things that we're doing on the national stage.
Exciting to hear about the work that you've done, and of course, the work that's yet to come, which tees me up well for our next slide, which is talking about the future outlook of CHW work. So one of the strict realities we need to face is that the One Big Beautiful Bill introduces work requirements, stricter recertification, co-pays for some groups, potentially increasing disenrollment and deterring care seeking, according to a review by the Urban Institute. The Centers on Budget and Policy Priorities estimates that potentially 10 million people could lose coverage by 2034 due to Medicaid cuts. So these coverage losses potentially increase demand for community health worker navigation and benefit support, while at the same time increasing numbers of uninsured patients, reduce billable visits, and produce strain on community health worker funding. So we need to deal with that challenge of supporting community health workers who are uniquely positioned to help bridge clinical care and community needs, and also have a great potential for expanding of their roles, and engaging in behavioral health advocacy and public health outreach work. So I'd like to ask each of the panelists, starting with Anna, to talk about what do you see as the future of the community health worker role?
I'm so excited, and I'm very, very honored to be part of this workforce because, like Treva said, CHWs are moving the needle. And I believe that the work that we do is very, very important. It's special. And I just encourage whoever supports or has come into agreement with being a CHW ally, like just support your CHWs, encourage them, help them, take care of them. I really see there being more CHWs coming soon, and especially with our political climate and just all of the changes. I really feel like we are going to be the ones to be stepping out and bridging gaps for sure.
Ton, can you talk a little bit about your views as well as your work on tracking and demonstrating the value and impact of community health workers?
Yeah, there are three areas that to me are very important. The first one is as we continue to make of CSWs a profession, I sure hope that we don't over professionalize it and that we get them out of the communities, that we are getting them to a level where they focus more on research. And it's important that CSWs are part of research, but I think it is important that their role continues to be what they do, and they know better than anyone else to tell them what to do. So that's the first piece. The second one, I think, is the sustainability for CSWs. We have nurses, we have social workers, we have doctors. Why are not organizations that are big enough that now they know that there is a return of investment on CSWs for every dollar that you invest on a CSW? In Kansas, you get $2.67 back. So that is proven already. Why are there not streams of money to hire CSWs versus depending on grants and having to deal also with Medicaid reimbursement, which is great, but at the same time, it needs to be complemented with something else. And the last piece is the recognition of the profession. which is very important. Nurses are great, social workers are great, but CHWs are great as well. And they have to be recognized as professionals and not as under other professions. I'm just going to stop there. Yep.
You.
Oh, I was on mute. Yes, correct.
No, you're fine. Just like you guys mentioned, everybody mentioned, and we know, there's a road, right, that we've been on, and it hasn't been always easy, but we've seen the growth that has been tremendous with community health workers. And I think the future outlook for community health workers is actually very bright. I think the reason for that bright future is because of the great need. So it doesn't matter, right, which way the administration goes, the need is there, right? And so because of what's going on here with the cuts, community health workers will be needed. If when ACA came out, community health workers were needed to help people to be enrolled. And so, as you can see, community health workers are needed. I mean, it's just simply put. And it is a unique role. Um, of folks like Anna who are out there not only, helping the patient, but they're learning about their community. They're being a voice for both sectors. And so I believe it's bright. And the more we learn about it and the more we're out here working and talking about it, the better understood it will be. And we'll continue to move the needle on healthcare in America.
Thank you. That's a great note to end this panel on. Um, I want to just say a huge thank you again to all of our panelists for participating in this conversation. Your insights and stories that you've shared are really inspiring and speak to the immense impact and benefits of the growth of community health workers across the country can have. I'm really excited to see that future grow and prosper. Thanks again. And I'm going to hand it back to my colleague Luke for a large group discussion.
Perfect. Thanks so much, Sarah. And thanks to Tan, Triva, and Anna for all the great input, the perspective that you shared here to really flush out some of those themes that came out of the focus groups. So, Sarah, could you go to the next slide? As we mentioned early on, we really want to have a conversation with you all and continue build off of what came out of those focus groups and the all the different perspectives and examples that our panelists had shared. So we have, if you go to menti.com and there's the code on the screen, 2473-9773. Want to start getting some ideas, or we're going to build out a word cloud here about what do you think are some of the greatest challenges for CHWs in this current environment? Want to hear some more of your perspectives. And we'll give it a minute here for everyone to get logged in to Menti so we can get the word cloud building. Also, if you have any questions or comments that you'd like to share or bring up, please feel free to plug anything into the chat or unmute yourself and ask your questions.
I'd like to thank the presenters. I think they were very insightful in their words and resources. They're huge advocates, and I've seen them in the heartland doing tireless work for CHWs. I just would like to see communities protect the CHW from a name change or a title change for employment with insurance companies and FQHCs. I think it's important that we remain true to the community in supporting, representing, and advocating for them. And it can be difficult when we align ourselves with hospitals and vendors of Medicaid and Medicare because they're looking for metadata more than outcomes of support and connection.
Thank you so much, Sherry, for jumping on and reminding of us of that connection to community to the community and staying grounded in that. Thank you. I still see some responses coming in, but funding, recognition, those are the ones that are really sticking out here, and many other items that are all related or are mainly related to those things. No, really reinforcing what some of those key themes that came out of the focus groups, as well as the examples that the panelists shared. Sarah, let's go ahead and go to the next slide. All right, our next question. What are the greatest training needs or support needs, I'll say too, for community health workers in this current environment? What are you seeing either because you are a community health worker or because you work with community health workers? Funding, yes. And I'll again say, if as people are joining these mentees are plugging in their responses, also feel free to come off mute or plug something into the chat to support or to ask any questions that you might have or add additional perspective to what was discussed today.
This is Jennifer Carter, and I'm from Ohio, the Ohio Community Health Workers Association. And I wanted Tom to say a little more about the professionalizing CHWs. I wanted to hear some more about that. Is that possible?
If they allow me, I'll be happy to, Jennifer. So one of the things that I have seen across the nation is there are CSW programs that allow the CSWs to do their work, right? So going into the community, helping people out with their needs, identifying what the challenges are, connecting them, doing the liaison between the health system, the social system, and the clients. I have seen some CSW programs that are embedded with certain organizations that they are trying to create a specific workflow that professionalizes community health workers in an area that prevents them from going out in the community. So that's one piece of it. That's the downside of it. When I talk about professionalizing CSWs in a positive way, is that there is a wide range of possibilities for CSWs to be working in specific fields. Like we have community health workers that focus on maternal health or perinatal care. That is a great way to professionalize community health workers. We have CHWs that took on the role of working with mental health professionals. We have CHWs that are working with substance use. Currently, I'm working also on the Missouri side to see if I can implement a group of CHWs that are going to be working with the police department. Because wouldn't you know, 75% of the calls that the police department is getting here are non-emergent. And sometimes when a policeman shows to the house of a family, that scares the crap out of the family. Sorry, I shouldn't have said that, but it is the reality. The families get scared. And then instead of that, having a CHW that collaborates with the police department, that can also go with there, you pair them up. And if it is a social determinant of health need, then let the CSW do their work. So Jennifer, that's what I'm talking about when we talk about professionalizing CSWs, just taking it to the next level and creating specializations for those CSWs. Does that respond to your question?
Yes. And I can see, I live in Middletown, Ohio, and I am on the council, the city council. And so I'm going to make a referral regarding CHWs and the police department because I think that would be really helpful for some of the people when you're going out on calls. I've seen just like Anna, she would be perfect to be out there with the police department. I can see her going into someone's home and helping, really helping. So yes, I thank you.
Absolutely.
Yeah.
Hey, Jennifer, I just want to encourage you to make those partnerships because I'm partnered with the EMS here in Mountain Home, and they'll call me because we are so well connected, and they're like, okay, well, this is something that Anna can help with. And because I know the community, I have the partnerships already set in place. I'm a familiar face, and they know that I'm connected with the Domestic Violence Council, with the Salvation Army, with the churches. So I just want to encourage you to do your thing, girl.
Thank you.
Yeah.
Thank you. And I truly appreciate you, Anna. I'm sorry I didn't see you at the conference. Were you at the conference in recently? Okay. All right. I will see you next time.
Yes, I would be glad to go. I presented this last conference. I was so nervous, but it was such a pleasure just meeting so many CHWs.
Yeah.
Yes, it was wonderful.
And I just want to add one other thing to this topic, or something else to the topic. Everything that was said is just is what it is. I get so excited. We get so excited about this work because we see the potential. And you mentioned the EMS. That's something we also do here in Kansas. But one of the other things that we're looking at is being innovative in the space. Um, we're working on, we're training CHWs who are in the prison systems, not only helping those who are, um, transitioning out, but also helping those who are in to learn how to help others navigate the prison system. A lot of times that's a whole community of itself, right? And people don't know how to navigate and don't understand their rights. And so that's another space. And I'm sure there are more out there. There's some, see, we've worked with CHWs in corporate spaces. And so the possibilities are endless. And like I said, the health benefits are tremendous. And I'll stop.
The conversation's going great, so I don't want to jump in and interrupt too much. But also want to put in there our last question that we wanted to ask you all for our word cloud is, how is your state taking advantage of the Rural Health Transformation Program to support community health workers? Again, feel free to, if you want to continue the conversation we were having a second ago, add to this one, add more questions. Please feel free to come off mute or plug anything into the chat.
Hey, look, can I say something real quick about that?
Please.
So one of the things that I see many directions here in Kansas as to, how the Rural Health Transformation Grant is going to be implemented. One of the pieces of it is obviously deployment of community health workers across the state, especially in rural areas that is very needed. A deployment of training, development of new training for community health workers. But something that I have seen, and I loved seeing this in Kansas, we had several meetings with different partners of the community, different organizations, including universities, K-State, which is a state university, University of Kansas, organizations like Trivas, where we all got together and we began to have those conversations as to what is needed here. And one of the things that is unanimous that we are seeing is the support for the Kansas Coalition of CHWs, helping them out with the needs that they have. Right now, they need a director, for example. So being able to, through those grants, to support the coalition, I think is very important because at the end of the day, it's supporting the CHWs, and that brings it back home.
Thank you, Tom. Any other comments, questions? I also want to be mindful of time. We've got about 4 minutes left, and there's one more quick thing I want to mention before we wrap up, but want to make sure there's time for any additional comments or questions.
My little mentee, no, CHWs getting a seat at the table. I think that has been vital here in Idaho. I think CHWs are now representing the work and advocating for the work in the realms of where people are going to be able to make change. So really getting a seat at the table, and I can just it's from here in this organization at Desert Sage all the way up into the state. So CHW is getting a seat and hearing us and knowing what our barriers are, what our challenges are, what exactly do we do, and voicing that. So I believe our state is doing very well in doing that.
Fantastic to hear. Thank you for sharing, Anna. All right. Sarah, could we go to the next slide? Okay, perfect. You read my mind. So one other resource that I wanted to mention just in our last minute or so is actually my colleague Sarah just wrapped up with this uh, this this pilot project that we had that she had run over the last year with a number of health centers from around the country. That it was a piloting a curriculum to help health centers develop, train and integrate community-based doulas within their care teams. So for many of these health centers, they were cross-training community health workers to be doulas. And Sarah actually just wrapped up this action guide that you can see via the QR code or find on our website for more information. Then with go ahead on to the next slide. So any last minute questions? I'll just open it up one more time before we wrap things up here. Awesome. Well, this has been a really amazing discussion. Again, thanks so much to Pfizer and the Multicultural Health Equity Collective for their partnership in this work. Thank you very much to our panelists for joining us today, sharing your perspective, from the community health worker side to the state and academia side. These are really important perspectives to be able to help us continue moving forward in this work. Please be on the lookout. I'll be sending those slides here probably tomorrow, the next day, along with the recording of this webinar, that you can share with any colleagues who aren't able to join or anybody else within within your network that you think would benefit from this conversation. We thank you all again. Hope you all have a great holiday season and hope to see you all again soon. Thank you.